So what we're looking at here is a vertebral body. This happens to be the fourth lumbar vertebral body. And the word spondy or spondilo derives from the Greek for spine. And spondilo, you will see many times a spondylosis or a spondylolisthesis. This is part of the spondy. This is part of, this is the spondy part. And the second part of a word like spondylolisthesis or spondylosis refers to the biologic process that's occurring. So spondylosis means it's an osis of the spondy, or in this case, it means essentially arthritis of the spine. So spondylosis is just a more specific way of saying arthritis of the spine. So the building block of the spine can be thought of as the vertebral body. We're now looking down on the fourth lumbar vertebral body. And I don't know if you can see my cursor. This is the body. And then there are some parts to it. There's what's called the pedicles, which are these parts of the bone that stick up. And then it forms this triangular roof over the top, and that's made up of the lamina. And then in the very back, this piece that sticks up, and that's the spinous process. And if you reach around and press deeply into the center of your lumbar spine, you may be able to just barely feel the tip, well, you can feel the tip of the spinous process. So this part is this part that's facing backwards. The front part is down at the bottom of your screen. Now I'm going to zoom this down and kind of rotate it around, and we'll look at it from a different view. And now you see to your right is the shape of the body of the vertebral body. And when we look in the back, we see these odd shapes. And on this picture, they're kind of gray. So now we're looking from the back. I'm looking over the spinous process. I'm seeing the lamina, which are right below me, just to the right. And then these circular things, these are the joints that are going to connect this vertebral body with the vertebral body above it. These are called the facet joints. And you can see each vertebral body has essentially 4 facet articulations, 2 going up. And then if I zoom it down and flip it around, it's got 2 going down. So the vertebral body below will match up and will connect to this facet joint. And this is important because facet joints have become very popular as potential pain generators in the spine. And you will see many people being referred for facet blocks or rhizotomies, cutting the nerves to the facets or treating them. But since these are true joints, they undergo degenerative process just like other joints, and spondylosis involves some arthritis of these facet joints, along with progressive changes in the intervertebral disc. Okay, we're going to leave this close-up view, and I'm trying to bring you to bring you back to a model, which we will do. We'll do the lumbar spine. Which for some reason is not giving me much. Let me go back here.
Again, if anyone has questions, feel free to submit them in the chat feature.
Oh, that was it. Hold on a sec. I had it ready for you. Just got to find it. Okay, lumbar spine. So this is the lumbar spine articulated, put together. And we're looking at it from the back. And at the bottom, we see the sacrum, which looks like lumbar vertebral bodies that have been fused together. And you see foramina where the nerves, the sacral nerves, come out. The lumbosacral junction we now see here between L5 and S1. And then just above it, we see L4 on L5. And this is where a lot of lumbar pathology occurs, partly because of the physical forces that are transmitted at this level. I'm going to, so you can see here the facet joints, and you see here we're looking at the fifth, zooming in on the fifth lumbar vertebral body, and you see the facet joint down to the sacrum, and you see it swerving up and meeting the facet joint for the vertebral body above. And inside, if we look inside, this is where the nerves run in that little house-shaped area that I showed you earlier. So let's add some nerves here. And we'll add a disc. Let's add the disc because you're going to hear about the disc when Dr. McCullen gets started here. So we see as we go around the back, now we're looking between the spinous processes and with the tissues all removed, you can see the nerves under here, which I'm highlighting. These are the nerves. The spinal cord ends at approximately L1 or L2 and to the cauda equina, and you see these multiple nerves that run down in the space behind the vertebral bodies and behind the discs, but underneath the pedicles and the lamina in that space that we looked at to start off the talk. And because they run in this closed space, this is the basis for many entrapment problems that develop in the spine and much of the pain. You can see that the nerves are exiting what's called the foramen. And the foramen is made up of, in this particular case, we'll zoom close up to this nerve. And we see that there's a space where the nerve is exiting, and the space is bordered by the vertebral body on top, the vertebral body on the back, and the disc, which I click here now is green. And then in the back, you can just see the facet joint, which is the posterior wall. So in many cases, we're looking at compression of nerves that occur because of a combination of bony hypertrophy, bone spurs, abnormal motion, and fragments of disc that may be bulging or herniating out, all of which can occur and put pressure on the nerve and cause referred pain, in this case down the leg in various places. So I know that we'll be talking more about that. I just wanted to give you a three-dimensional sense of where we are. Any questions about the three-dimensional anatomy at this point? I'm getting ready to turn over to Dr. McCullen.
No, thank you for that, Dr. Crabb.
I guess, yeah. So was one other thing. No, let's just go right to Dr. McCullen. Jeff?
Yes, I'm here, and I'm going to go ahead. Do I have to wait for you, Ian, to? Okay, I'm right now. I'm going to share the screen here, and bear with me. Hopefully, you're seeing a slide that says Merit Medical office hours.
Yes.
Great. Thank you so much. I'm going to take us back to 2 dimensions. I love seeing the 3 dimensions. That I put this slide on to show people and to orient to the soft tissue parts. So this is 2 lumbar segments seen from the side, and you'll recognize the vertebral bodies above and below, and in between the intervertebral disc. You'll notice the space for the neuroforamen where the nerve will exit. And as Dr. Crabb pointed out, that is between the disc and the facet joint. This is the area of the facet joint, and there is capsular ligaments that attach the facet joint. And there are also ligaments that span between the spinous processes. There's a long ligament that attaches to the tops of the spinous processes. And as well, there are ligaments that span along the back of the vertebral bodies and back of discs, and along the front of the vertebral bodies and the fronts of discs. It's the combination of the anatomy of the vertebral bodies and bone, as well as the soft tissue parts, the discs, the capsular ligaments, and the ligaments that span between the bones that make for the spine to be strong and stable. This is an MRI lateral view, similar to the image that we just looked at, and you'll recognize the features. The vertebral bodies are the squares, and in between the vertebral bodies, you have discs. Just behind that, you have the space for the nerves. And in fact, as Dr. Crabb mentioned, the spinal cord ends typically at L1 up here, and from there is called the cauda equina, which in Latin means horse's tail. So you can actually see some very spaghetti noodle type nerves as they're coming in a fluid-filled space. This fluid is what's called the cerebral spinal fluid. And behind that, you see the spinous processes here. If you look closely at these discs, you can see that there are some great looking discs here and some partially worn discs here. A partially worn disc will turn dark on an MRI, meaning that it has less water content and it might bulge on its edge. These are typical age-relating or degenerative findings that we see commonly on an MRI scan. This bottom disc is a very degenerative disc. It's lost intervertebral disc height, and the edge of the disc has protruded posteriorly into the nerve canal. This is a figure showing an axial view. And so you can think we've sliced away through the vertebral body and spine, and we're in a kind of bird's eye view looking down on the vertebrae, including the nerve space. This space here in the center is called the central canal, and you can see this green neon. This is the dura. This is the membrane that surrounds the nerves, and the nerve roots are inside, floating in the fluid-filled sac. Just laterally to that, or to the side, there's an area which is called the lateral recess, and this is the area just underneath the facet. As the facet degenerates and becomes hypertrophic, thicker, and maybe bone spurs start to form off the edge, it can narrow this spot, this lateral recess. So that is called lateral recess stenosis when narrowing occurs in this region. The nerve roots are going to exit through a channel here, again, behind or just underneath the facet joint and between the edge of the disc and the facet. So you can see it's naturally a small area. The nerves do have enough room, and that area is called the neuroforamen. Different problems or changes within the facets, including hypertrophy or bone spurs, or different problems of the disc in this region with disc protrusion can cause narrowing of the neuroforamen. This is an MRI axial view looking at the same thing we were just looking at. This is the edge of the disc, and in fact, in this case, you can see that there's a broad central disc protrusion. If you look at the facet joints here and here, there are degenerative changes of the facet joints. The space for the nerves is slightly narrowed as a result of a combination of the disc as well as some of the hypertrophic changes that are occurring in these facets. These are nerve roots that are exiting far laterally from the nerve space. Up here on the top part of the image is the abdominal area, and back here are the posterior paraspinal muscles. So discs are under a lot of load and a lot of mechanical compression, and it really is not uncommon for them to have, especially the lower discs in the back, to have mechanical changes. And they can start to stretch on their edge and even protrude or extrude, where the center portion of the disc, which is called the nucleus, you can think of that as the gelatin or the jello in a jelly donut, protrudes through the outer layers of the donut into the spinal nerve space. And so this demonstrates some of those locations where discs are protruding and are called disc herniations. So the blue line shows when you hear about a broad disc bulge, you'd see the edge of the disc being broadly stretched. If you hear about a central disc protrusion or central disc herniation, that would be here in the central canal. And a paracentral, which is probably the most common, is just off of midline, and it's in this space that is called the lateral recess. And you can see why if a disc herniates in this area, it can push the nerve up underneath the lamina and compress the nerve into that space. And then there can be what's called a foraminal disc herniation, which is this green, where there's a disc that sticks out here as the nerve root's trying to exit. What's not shown on this figure is a far lateral disc extrusion, which is uncommon but can occur. It just like the name implies, it's sticking out far laterally, and it will catch the exiting nerve root far laterally in this zone here.
So Jeff, before we go,
yes,
can we go back to that?
Yeah, let's go back.
I have some questions. So, because this often, when we get an MRI report on, it has multiple disc bulging and may have a small, there's different terminology that's used, and occasionally you'll get a report that there's a frank herniation, but many times it's a little more vague. So the question is, how do you interpret these types of findings from, is there a link between the finding that you have on this and the acuity of the process? In other words, do you see a herniation as an acute injury and a broad-based disc bulge as a non-acute injury, or how do you think of that?
Yeah, so to your point, when a radiologist reads an MRI, they're going to point out every single small feature. The analogy I'd give you is if I was selling a used car and you wanted me to describe that car, and I went out and described every little area, whether it was rust or a pull in the fabric of the seat cushion, you could really get a lot of detail. The question is sometimes what detail is important among all of the findings. What is the most important thing? What is the issue that's at hand? Because frankly, as we get older, we're going to all have different types and forms of degenerative change, and those degenerative changes in the spine occur in the discs, especially the lower discs. So to find degenerative disc change, to find broad-based disc bulge, to find central disc bulge, or even herniations is very, very common. And so to your question, sometimes you can have an acute pain, but the findings are degenerative or appear older, and it is hard to see that any of the issues are acute. I wish it was like this picture here where an arrow would blaze on the MRI that give us, a differentiation of an acute versus a chronic problem. But maybe what we do best is if we combine the imaging review to the detailed history and physical examination, and it's the combination, right, of the history, the past history, the mechanism of the injury, and the symptoms, physical findings, and then the imaging. Then you can, I think, start to create both what I was saying before, what among this is important, and then maybe what among this is new or possibly fresh or different. And it takes the combination of things to bring that to bear.
One of the things that I was going to show briefly, I didn't bring up, and you may be getting to it, so I apologize, but it seems like a good moment. Just to be clear, the nerve root that's coming out at any specific level has a very specific path that it's fated to innervate. In other words, at L4-5, there's a nerve that's going to come out, and it's going to go to the lateral leg. And we know from neuroanatomy where those go, what innervation, what the nerve does. And that's called a dermatome, where we know the sensory implication of that nerve, and we also know the motor implication of what muscles that should innervate. And one of the most useful things in the physical examination is to correlate the findings in a dermatomal manner with where the MRI suggests there may or may not be a disc bulge. I don't know for you, Jeff, but certainly for me, the finding of non-physiologic numbness or weakness helps to sort out whether I believe a disc finding is real or incidental.
Yes, so exactly, and I'm glad you're reiterating the point that each nerve has its own function, and fortunately, most people, they're pretty similar. We're not all exactly the same, but generally, an L4 pattern is pretty specific, or an L5 pattern, and so you can differentiate these nerves at their courses, their signs, their symptoms, and anatomical findings. And when you have, this is a very important point. If you have back pain alone, or if you have a broad pattern of leg symptoms, let's just say, somebody says, well, my entire leg hurts or feels numb or is weak. And the broad pattern would not be physiologic to a nerve root, or maybe even two nerve roots. To get the whole leg to be numb, tingling, and weak would take 6 simultaneous nerve roots. So that's what we start to say, it's non-anatomic or not physiologic, especially if it doesn't follow. Now, back pain is a tricky deal, because where pain is coming from the back still stumps us as a field. We can hear of terrible back pain and have normal MRI, and we can also hear of no back pain and see a terrible looking MRI. So to correlate an MRI finding to a symptom of back pain is really not what we should be doing. It's just not specific enough of a test. So we really have to watch. As you can see on these MRIs, you can see a lot, right? But you don't want to get carried away in terms of what you're seeing is the source or cause de facto of a symptom, especially if that symptom is broad and non-anatomic.
Yeah. So, and just to say it one more time, we are clearly distinguishing the clinical entity of back pain from the clinical entity of sudden radicular symptoms down the leg.
Right. These are two clinical different scenarios. They do share that the back is overlapping, meaning the back is the area, but really what is within that area is different if you're looking at a radicular pain or radiculopathy versus a back pain.
Right.
So good points. I love it. Here's a an MRI, similar style, but this is a smaller disc. So you can see they come in different shapes and sizes. And here's a larger one. So sometimes, you know, where they are, what they look like, how large they are they correlating with the history, physical examination? This is what we use to determine if what we're seeing is the issue. I wanted to point this one out. This is, if you remember this one, this was from a slide that I just showed a little bit ago, showing a central broad-based disc protrusion. And the person continued to have pain. So they had an updated MRI 7 months later. And I thought this was interesting because the disc now, and this is the same level, it is gone. So the issue about discs is they can resorb. And this is an example of a disc resorption. So not everybody needs to have a disc removal. And in fact, many disc protrusions are just there, just leave them alone. We've talked about facet joints, and the issue about facets is they are synovial, meaning like your shoulder or your hip and knee, these joints have a capsule and then synovial fluid that surrounds the cartilage surface. And so just as a wrist has cysts that can develop off of the joint, so can the spine. And this is a MRI scan seen from the side. So you're starting to recognize here the view of the vertebral bodies and the discs. And then within the spinal canal, there's a very distinct circular cystic structure. And you can see the kind of narrowing, at least on this view, that it can create for the spinal nerves. This is the associated axial view through there, and this is the edge of the facet cyst. And you can see how much of a space occupier it is. Now, this is the facet joint, very degenerative. For this cyst to be built or created, this is a long time in the making. This is, first of all, a lot of mechanical wear and tear, years in the making of a facet joint, followed by the development of the cyst that comes off of that joint. These are the nerves here. They're over in this corner and they're pushed over here. And so it wouldn't be considered unusual really for this person to present with leg radiating or radicular style pain occurring as a result of nerve impingement. And when the MRI is done, it shows, you know, there's a little nerve here caught in the corner, and all these nerves are bunched over here to the side, and this large facet cyst. This is a CAT scan, different patient, but I wanted to show how CAT scans look different than MRI scans, and really why sometimes we get a CT scan versus an MRI. First of all, what you'll notice is the bones really are more clear. And so you could say that a CT scan really shows the bone and the edge of bone very, very well. This is a facet joint here, and this is one here, and this is one here. And so you can see joints also well, primarily because you're seeing the bone well around the joint. If you compare this joint to this joint and then this joint, you can see this joint is degenerative and is and there are some bone spurs that have occurred off of the edge. Likewise, look at these large bone spurs. So bone spurs are very common and occur as a result of degenerative change. These up front on the spine, they're not in an area to place pressure or irritation on a nerve. So they're just there hanging off the front of the vertebral body. If you look at an axial CT, you'll see that the space for the nerves is hard to see. By the way, this is a CAT scan without contrast, so no dye has been inserted into the dural space, into the CSF, so you're not getting any contrast there. But this is the general space where the nerves are, and it was brought out earlier that within the process of facet degenerative change, you would have degenerative change occurring in the joint and then thickening or hypertrophy of that facet. And this is that same facet that we saw on the last view. It's extremely degenerative. This is some calcification of the ligaments that attach here, and this is a big bone spur hanging off the edge of the facet. So you can see, as a result of degenerative condition, how you can get a narrowed space in the central canal, in the lateral recess area, and then in the neuroforamen area where the nerve's trying to go. And this is all a result of the significant disease of the facet occurring from degenerative disease. I'm going to switch gears to the vertebrae. And this is an MRI scan showing the vertebrae. And you can see the kind of the shape and size is a cube. And you can also see, and I want to point out that the alignment is such that in the usual situation, the vertebrae stack very evenly, one on top of the other. Again, you'll recognize the end of the spinal cord here and the nerve roots of the cauda equina dangling down. Sometimes you'll hear about a wedge or a wedging or a vertebral compression. This is when the normal cube shape of the vertebral body is distorted and made into more of a wedge-shaped. This is a CT scan showing a osteoporotic compression fracture. So again, the normal shape from a square is pushed down into a wedge, and you can see that in this case, this person has poor bone quality. When you compare it to that CAT scan that I showed you before, where the bone was very white, you can see this bone is kind of not nearly as white, just very barely white along its edges, and in the center, it just doesn't have the same bone quality. So this is an example of a person who has osteoporosis, and those folks can get compression fractures very easily. If you have normal bone quality, it takes a lot of force to create a compression fracture. This person had a compression fracture just falling from ground level, but that would not be typical in a person with normal bone quality. This is a front view, or what's called a coronal view, and you can get another perspective on this crushed vertebral body and its edges and compare it to the shape and size and dimensions of a normal vertebral body. We've talked about the spinal space for the nerves. I'm going to highlight that again. If you have seen the edges of the vertebral bone stacking up evenly and the posterior elements here not intrusive, you can see the space for the nerves has plenty of space, plenty. It does as it gets down here into the lower part of your screen, into the sacrum, it's going to start to narrow just naturally. But if you compare this to what happens with the person who is faced with advancing degenerative changes, and they will start to narrow the central canal. The narrowing comes from both the backside of the spine, where there's thickening of the ligaments and thickening of the facets, and then from the front side, where there's bulging of the discs. The other thing I want to point out is if you follow your eye along the back margin of this vertebral bone, it doesn't line up with this one. So this is what Dr. Crabb was talking about earlier. Between lumbar 4-5, there is a spondylolisthesis, a forward shifting of lumbar 4 forward on lumbar 5. This is common, and it occurs as a result of the repetitive degenerative changes at the L4-5 level, the fact that the facets are degenerative and they're compromised in terms of their overall ability to hold that structure straight and not allow that shifting. And it's often associated with stenosis, narrowing of the space available for the nerves. And this is an example of, on the right screen, a severe multi-level spinal stenosis.
Now,
I'll
Jeff,
point,
before
yeah.
we go on from this, because every MRI scan you get on a 60-year-old worker that I see, they all have L4-5 degenerative spondylolisthesis to some extent. Maybe that's an exaggeration, but a lot do. And what are the symptoms? So go ahead and just tell us a little bit about the symptoms you'd expect from spinal stenosis. And I guess I wanted to be clear that this is not a traumatic event. This is a natural process as part of aging. Yeah.
Yeah. So great points. Thank you for those. And yes. So when you hear of a person who has symptomatic spinal stenosis, the most typical thing they'll be describing to you will be that when they get up and walk, they feel pain or heaviness or weakness in their legs. And this might occur when they walk a mile, or it might occur when they walk even distances as short as length of a hallway, 100 feet. And they sit down and the symptoms usually resolve within a few minutes, and they get up and they walk again. They do find that if they bend forward just a little bit, they might reduce some of the symptoms that they're experiencing in the legs. So if they lean on a shopping cart too. So what I was going to say is you might go shopping next week, and if you watch people as they shop, you might identify a person with spinal stenosis. They'll be leaning forward, they'll be leaning on their shopping cart, and they will seem fairly comfortable if they're doing that. But if they're walking without any kind of lean or any kind of support from the shopping cart, then you might see them stop and have to sit. And this is the typical kind of constellation of symptoms, if you will, that occur as a result of degenerative disease that's caused spinal stenosis in the low back. It's different, isn't it, than what you might have heard with someone who has a disc herniation, which is a single nerve is hurting from the lower back down in a particular pattern of that nerve into the leg with associated numbness, tingling, or weakness in that one nerve pattern. In this case, you're squeezing the entire spinal canal, so the symptoms are more broad, and they are both legs, and they are relieved by rest and worse with walking.
Excellent. Thank you.
Thank you. Thanks for the question. I was going to point out that you might, on this far right, there's an incidental finding. There's a small cyst down here. This is a Tarlov cyst. It's a clearly benign cyst. It's filled with cerebral spinal fluid. We're at near the end within the sacrum, and so this does not, except in very rare situations, cause any symptoms. So it's clearly just an incidental finding. But I mention it because sometimes in the course of the radiology report, they'll comment on an incidental Tarlov cyst. This is an extremely bad extent of stenosis, and like the other image that we saw, it's a multi-level situation where the discs have lost their height, the edges have protruded broadly, and in this case, this is a case of retrolisthesis, where this vertebrae, the L3 vertebrae, has rocked backward or posteriorly compared to the posterior edge of L4. So while we see maybe most commonly anterolisthesis or forward slipping at the L4-5 level. In the lumbar levels above that, including L2-3 and L3-4, we might see retrolisthesis or posterior displacement of one vertebrae on another. And you can see in this case where the retrolisthesis combined with the broad disc protrusion creates a severe spinal stenosis. There's thickening ligament posteriorly. This is called the ligamentum flavum, and this is ligamentum flavum. And so you can see how ligament from posterior and disc from anterior and the retrolisthesis combine to make severe spinal stenosis. This is an axial view showing severe spinal stenosis, again, as a combination of multiple factors of degeneration, the broad-based disc protrusion. This is the nerve space here. It's really down to about, well, maybe a 20% of its normal space available. Thickening of the facets, thickening this dark rind here between here and here. And here and here, kind of like almost a bat shape. If you see wings of the bat here and here, is the ligamentum flavum part of the ligament?
Jeff,
yes, sir.
So we have only about 15 minutes left, and this is great. I want to make sure we get into some of the clinical questions, and I want to ask you a little bit about your perspective. So we've been talking a lot about the anatomy. We've been talking about things that are clearly identifiable: compression fractures, spinal stenosis, and disc herniations. And we've been talking about sort of the gold standard cases, if you will. Now, what about how do you evaluate many of the cases that we see are 40-year-old, 50-year-old workers with back pain? So how do you approach those cases? Where is, say, facet joint pain on your differential, or and you may be coming up to this, so I don't mean to steal your thunder, but I want to bring it around a little bit to the clinical situation and pick your brain on that.
Yeah, so to reiterate that I'll use all the features of the history, physical examination, and imaging to try to discern the nature of the diagnosis. And I'll recognize that people will show a significant amount of degenerative changes pre-existing in their spine. And so I don't want to get caught chasing a bear up the wrong tree. In other words, I want to use those features to help to distinguish and then hopefully boil it down to a more than a theory, maybe a strong conviction that the source of their symptoms might be coming from one particular area or another. I'd like to tell you the process is always simple and it's always certain. The truth is that we kind of develop theories when piecing together all of the information, and we exercise our theory by developing a treatment plan, and we watch what happens, we hear what happens as the person's engaged in that treatment. Often it's in fact, almost always it's a non-operative treatment approach initially, and then we see what time and that non-operative approach brings from the way of symptoms, symptom change, symptom improvement, or sometimes worsening, and we readjust. So it's an iterative process, Ian, of listening and watching and using all of the different information sources that we have, and not getting too focused on one image more than another. The best time where we have the best results are when we have a very classic situation of a mechanism and of a physical finding and of an MRI, and it all matches. I'm sure many people on the line realize that's a rare incidence. What we have is usually much more muddy scenarios, and we're trying to sort between them and not get too focused on one thing more than another as we do so. And I've been focusing here on imaging, and I'm going to just go quickly through this to try to show people what what the spine does when when we act on it. This is a case of a fusion, for instance, and the degeneration continues. So we have a natural process that continues to go, and surgery doesn't solve that problem. It stiffens the area, and we just have an ongoing moving target. This is an example of someone with vast problems with their spine after surgery. Surgery didn't cause this. Surgery was done to try to open up spaces, but the process continued. We
do have a question from the audience real fast. Jolene is asking, what is an annular tear?
An annulus is the outer edge of the disc, and it's multi-fiber, meaning it's like a car tire radial tire, or maybe you can think of it like onion layers. So they're fibrous and they're in sequence, and so they can start to stretch between those layers, and you can see it as an annular tear. I think this is an example how sometimes it's pointed out, maybe on a radiology report. It's not typically the major, fish on the line, but it can be a major distraction, in my opinion, because some people do harness a lot of belief that that terrible annular tear. In fact, the word tear is, I think, a misnomer. I would maybe call it a fissure, and I would also claim that it is common and it is part and parcel of a degenerative processes that happen to the spine. It can't be related to a single event or a single injury.
Good. Thank you, Jolene.
And so what I wanted to show on this slide is that there are referred sources, and I do try to keep in mind this is a person who has hip disease, and sometimes hip disease can be can mimic spine disease in terms of some of its strategy, but we'll always wiggle around people's hips and to see if that, and or sometimes image the hips to see if that is the potential provocative point. But why I moved quickly through that is I wanted to bring up this article, which I found interesting. This was from 2015, and they looked at 15 articles that had MRI'd people who are asymptomatic of different ages, and a total of 3,000 patients among 14 studies were combined into this single study. And what you can see is, if you look at the results, is as one gets older, yes, the extent of findings on an MRI continually increase to the point where you're, in your 70s and 80 years old, you're almost destined to have. And so you'll see on this slide about three quarters of the way down, annular fissure. Annular fissure in 20-year-olds, that's a common finding of 19%, and it gradually increases to 29% in an 80-year-old. But what I'm pointing out here is this is a common finding. It's a non-specific finding. It doesn't really have much physical findings attached to it. We shouldn't go doing major surgery for it. It's just a finding on an image. And then disc degeneration, we've really hit that hard today, showing various issues on imaging. And you can see how at a 20-year-old, we'll have a 37% disc degeneration, and an 80-year-old, 96%. We've talked about facet degeneration in a 20-year-old, 4%, and in an 83-year-old, 83%. What about that working age group? Well, that's take a look in the 20, 30, and 40. They keep increasing, and those numbers are not small. Disc bulges, loss of disc height. My point is, yes, you can look at an MRI, you can read the MRI report, you can see all the different findings. You have to combine that with the history, physical examination to make an accurate diagnosis. So that's what I wanted to emphasize today. We were talking about anatomy, and we were talking about what happens when spines naturally wear and degenerate in the course of one's life. And so degenerative findings are very common, and they're very common, like that last slide that I showed, in asymptomatic people. And they are minor events happen to all of us throughout our lives, and minor events don't cause serious or major spine conditions. So take caution when attributing a minor event to a degenerative imaging finding, and use and always correlate the history, the mechanism, the exam, and the imaging before making a clear-cut diagnosis, and especially when and before proceeding with major interventions such as significant or severe spine surgery, fusion surgery, etc.
That's actually another question we have. Jolynn asks again, it seems like every time a disc bulge of any kind is found, surgery is recommended. What symptoms need to be present for you to recommend surgery?
For me, the symptoms are not back pain. Back pain alone does not warrant a surgical intervention. A disc protrusion causing nerve symptoms that are significant and functionally limiting and identifiable and objective on exam. So we're talking about strength, reflexes, motor changes, reproducible findings indicative of a nerve root pathology, radiculopathy that's correlative to the MRI findings. So if you have a disc bulge, but it doesn't correlate with anything, it's not something that you would operate on. If you have a disc bulge that is causing, or protrusion that's causing, significant narrowing, and that correlates with the symptoms of leg radiating pain, and it correlates with the exam showing a radiculopathy, then that means pain radiating down the leg with associated tingling, numbness, or weakness. Then you might have an operative indication. Again, I will almost always try non-operative means, even in that case of the radicular findings. I would try some rest time, activity modification, physical therapy, and possibly an injection. Now, if the pain is severe, such that, and none of those non-operative methods are working, then surgery is a good option.
Jeff, is it still the case that for simple lumbar disc herniations, the outcome at 1 year is the same, surgical or non-surgical?
Yeah, so they've studied this. I would say that what you'll see in the studies is that the result is faster if you have surgery. The improvement is faster. So it's like the tortoise and the hare, excuse me. So if you want to get better quicker, surgery is the best approach for that group of patients. Again, a disc extrusion, protrusion that's causing radiculopathy, then waiting it out. But if you did wait it out, you might gradually get there. What might get better in 2 years might have been better in quicker time frame with surgery. So while I generally I'm very conservative with surgery, there are times where surgery is the better approach from a point of view of taking the pressure off the nerve, providing relief of that nerve, and getting the person moving and active again.
In a person that's had a significant lumbar disc herniation and has some documentable motor weakness, let's say you're 3 months out from the injury, is there, what's your expectation in terms of recovery of neurologic function? Do you expect to get neurologic function back in that case, or just prevent further worsening?
So the degree of neurological dysfunction before surgery does correlate into what we're seeing post-op. In other words, someone with a foot drop and they've had that foot drop for more than a few weeks, we'll be waiting a long time and perhaps have a lower rate of neurological improvement. I think generally people take 6 to 12 weeks to heal up from a discectomy, and most of the time they'll notice that their strength is improving, even pretty shortly after the surgery, except in those cases when it's profound weakness and there has been a, substantial delay to get to where you need to go. So, so if you have somebody who has, a foot drop, tibialis anterior weakness, large disc herniation, that's you want to move along with that. In fact, you don't want to necessarily, I would not obstruct them getting the MRI.
Right.
MRI, it's weird because MRI is going to pick up everything and sometimes cloud the water. But if you have a person who has had, no significant spinal history, suddenly having severe pain radiating down, they can't walk and foot drop, I would get the MRI quickly. And I would operate, assuming they find correlative findings.
So another question, a case I just had earlier this week, a young person, I'm going to jump the tracks to a cervical question for the moment. It's a youngish person, I think 50, big disc herniation, came on while she was working, lifting some parts. What would you say, and very little degenerative change in the cervical spine. So minimum degenerative change, new onset, disc herniation, very, very correlative physical examination. From a causation standpoint, would you say that a disc herniation that occurs at work while you're lifting some stuff is always a compensable injury, sometimes a compensable injury, or never a compensable injury?
Well, I love that question. We need a whole other hour for that one. But in any case, and you always have to be fearful to try to answer a very, very challenging question with a little bit of information, enough to make it hazardous, and then to do it quickly. So people are,
and I don't mean to stump you
yeah.
here. I'm saying that based on the information we have no pre-information that there's any weakness in the spine beforehand. It's a normal appearing cervical spine. There's no degenerative change. So often we see these cases where it's a combined degenerative change and a disc. This is a pretty normal looking spine, big disc herniation.
So what I would tell you is, we look at causation and there are multiple factors. One of them is timing. Does when equal why? No. An analogy that you've heard, Ian, is when the sun comes up when the rooster crows in the morning, so the rooster's crow brings up the sun. Well, no. So doing an activity made the herniated disc because the pain happened when the activity was done. Well, the timing is just one feature. You would look at the entire activity and the nature of the activity, and you'd have to really recreate that to understand the influence of the activity itself. Right. So yes and no. In that case, I would say yes, they developed a herniated disc while doing the activity. Did the activity cause it? Well, I have to know more about the activity. I have to probably do more an analysis that way. To understand whether the activity itself, did it happen just at work? I mean, people get herniated discs throughout the course of their day. It's not necessarily the activity they were doing when it came.
So a herniated disc might occur without any external load, just sitting there.
Yeah, so there's the most common reason for persons to get herniated discs, whether in the neck or the back, are that they are working on a degenerative change slowly over time. And it's just kind of was the last final, we've talked about the annulus, it's stretching and then, boom, and it can happen without a lot of force. And in fact, if I question my patients, well, what happened to you? Most search their brain for what it was, but many of them say, I'm not really sure. It just started to hurt, or I woke up with it. Well, that's just when the symptoms became noticeable. But And again, it's a continuum right through the process, and then the final ping. And maybe for a lot of listeners today, they say, well, that's the linchpin, right?
That's the compensable moment.
Yeah, it's
Right.
the compensable moment, that final little dink, like I lifted my pencil and, I got terrible pain. Well, that's not a lot of mechanism on the
Right.
spine. So I wouldn't say that that's compensable for the final ting, it's just final tongue itself at that time. But other things maybe, but I would say that from my angle, to be clearly compensable, it'd have to look at the case, and it'd have to be, to me, a discernible, distinct event that was one that is known to or likely would produce biomechanical stress that would, cause a problem. I wouldn't just, I don't do this, like ask the patient, what do you think happened? Well, I lifted my pen and I had pain, so the lifting of the pen caused the pain. Well, that's what they think, but you have to look at it deeper in that. What were they lifting? How were they lifting? What was the position? Right.
Awesome. We are all out of time.